Right. Today we're going to talk about in the conceptual basis of urology course, management of urolithiasis and pregnancy. I am Hamad Athar. I am professor of urology at Aga Khan University in Karachi. And we are very fortunate this evening that we have a panel of experts. Dr. Nadeem Zubairi, Associate Professor, Gynecologist, Obstetrician at Aga Khan University and a long-term colleague. And we have worked together for many, many decades now at Aga Khan. My dear friend from Nepal and president of Nepal Association of Urological Surgeon, Dr. Mahesh Adhikari, himself an expert in the management of urolithiasis, and my mentor and friend, Dr. Nasir Suleiman, with whom we have managed a lot of these cases in our over 25 years of associate. So welcome to all three experts, and I hope your input will be very valuable during the course of this interaction for the next 1 hour. So this is the 29th webinar of our series, and this really started off in December 2021, where we had 2 webinars. Last year, we had 22 webinars. We used to do it every fortnight. And then this is the 5th webinar of this year. This is by Karachi chapter of the Pakistan Association of Urological Surgeons and Aga Khan University. All these lectures are recorded and they are available free and easily accessible to all of you in the PAUS Karachi chapter website. And Sharif is going to paste this address on the chat box and you can copy it if you're interested. So today we are going to talk about the urolithiasis in pregnancy. And it is really a group of conditions that we deal with as endourologists. Urolithiasis in urinary diversion, urolithiasis in anomalous kidneys, like the most common of which is horseshoe kidney, malposition kidneys, like malrotations, malrotated kidney, and ectopic kidneys, and calyceal diverticular stones. So these are complex situations that we deal with, and sometimes we have to deal with urolithiasis in pregnancy. Now, this is a really complicated issue, and we're going to share some of our experience and the gathered experience of the urological community. So why urolithiasis in pregnancy is an issue? Well, first of all, it is a relatively common condition, and it is seen in 1 to 200 to 1 to 1,500 pregnancies. So this is fairly common in areas where urolithiasis is endemic. Again, it's a significant condition. Pregnancy itself predisposes to urolithiasis. So if you even are not a stone former, you're likely to form your first stone during pregnancy. And we'll talk about why it is so. Unfortunately, it's often an acute presentation, and it is often also associated with sepsis. Diagnosis is a big challenge, and it is predominantly because that you're handicapped by the use of imaging during pregnancy. Management itself is, we have limited armamentarium, both in terms of conservative and medical management for pain and sepsis, and also that endourological interventions are relatively compromised because of anesthesia and related issues. Whenever I see a patient of urolithiasis in pregnancy, I always remember this case that I've managed, I think nearly 14, 15 years back. And it reminds me of some of the very basics in surgical management of conditions. This was a 24-year-old primea gravida. She was 27 weeks pregnant at that time, and she was referred from an outside unit with failure of the conservative treatment. She continued to have significant pain, and whenever I see her, she is often crying with pain. We have been using everything which is permissible under her condition. She had profuse vomiting, and she started running fever as well. The ultrasound showed that she had bilateral hydroureteronephrosis, and the urethral jet on the left side was there, but there was very sluggish or no urethral jet on the right side. This is where she had pain. And as you can see in the ultrasound, the bottom of the picture on the right side, that there is a stone in the distal ureter. So once we have tried everything and we couldn't succeed in managing her condition with conservative treatment, we start looking for other options. And these are some of the options I thought are available to us at that time. And I would appreciate if our colleagues can write in the chat box the option that they would select in this 24-year-old, 27-week primary gravida with failure of conservative treatment with the right-sided obstruction and urethral stone. And our experts can look at the results, and then we can comment on these options. So if our colleagues have already voted, and I can see that majority have gone for option D. Yes, so majority have opted for option D. Some have gone for A and B as well. So Nadeem, what would be your advice to the treating urologist in a situation like this, when you have a 24-year-old primary gravida, 27 weeks pregnant? She is in a relatively safer period of the second trimester now.
Yeah.
So
if I see such a patient, then the first thing would be to increase the hydration on that. And one can also would consider, obviously, from a urologist perspective, any MET, which you prefer, like using any nifedipine or alpha blocker, can potentially be used in the second trimester, which is an option there. Although the alpha blocker have little bit of a controversy, but it is usable in that. But once it comes to an obstruction, then one need to go into the mode of either using, probably suggesting them to have a pain control of some sort, like paracetamol or something, because aspirin and these things are not the best of the choice for these patients. And maybe that would remain your jurisdiction to decide on that, whether to go for a DJ stenting or do a PCN insertion under ultrasound. See, two of these, I would be more inclined to think of with a urologist to consider. This is how I would see it. And sometimes
Dr. Mahesh Adhikari,
people have used.
Sorry, Nadeem.
Some of the people have also used continuous long-acting sort of epidurals in these patients, also in the pregnant patients. By the time they are going through the process of this or making a decision, slow, continuous sort of epidural has also been used by people. So all these options are available, but ultimately now, because the obstruction is there and the chances of infection and other things will go high, the first temporizing, probably, if you are temporizing it, then a DJ setting or PCN, or if you're going for a definitive, then maybe US or something could be considered from obstetrical point of view. But obviously, that is more of your domain to decide.
Dr. Mahesh, majority have voted for D. Would you agree, or would you go for a temporizing major at this point? Oh, we can't, you are muted.
Okay. Yeah, most important thing in these days is we need to discuss with the patients. Because in our context nowadays, the pregnancy has become very precious. Young parents, So most important thing is we need to discuss with the patients regarding all these options, and then the complications and the consequences regarding continuation of the pregnancy. Everything has to be discussed with the patients. Obviously, the guidelines also said uteroscopy in second trimester is quite safe, and there has not been any difference in complication between uteroscopy and JJ stent, PC, and everything. But recently, I have managed these similar cases. I went for patients actually opted for PCN guided PCN under ultrasound guidance, and then we changed the PCN a few times because of all these incrustations, obstruction, and everything. Yeah, safest thing is I think PCN, but if you patient agree regarding the uteroscopy should be the right treatment, sir.
Right. Thank you very much. I think that's a valuable comment.
Ahmad, can I say a word here?
Yes, please go ahead.
And what I can recall is that the use of URS and lithotripsy is more of a preferable if it is a second trimester and onward pregnancy and the stone is less than 1 centimeter, there is no infection, the patient is preferring for it. While in the first trimester, and if the renal function is going down and it's a stone is a larger one, then PCN or DJ are the more preferred choice. But when your case is a second one, second trimester, then maybe in this circumstances of a second trimester, because of that, one may consider URS and lithotripsy.
Agreed. I think we'll go a little further details and discuss the various points raised by our panel and those which are there in our chat box by our delegates. So I discussed options and temporizing measures like a percutaneous nephrostomy and internal stenting. The problems with these things, particularly with nearly about 12, 13 weeks still to go, is that these stents and nephrostomy tubes have to be changed frequently. And this is not one-off a procedure and will last through her pregnancy because there is a high rate of incrustation of these foreign bodies. So she may require another procedure in few weeks' time. So considering all those things, and as Dr. Adhikari has also explained, that you need to talk to your patient and make a joint decision. So she's an educated lady, and she said that go ahead and do something and sort this out for good. So I decided to do a ureteroscopy, right-sided distal urethral stone, and we did a ureteroscopy. I'm in the ureter. There was a bit of a difficulty in negotiating the distal ureter. The rest of the ureter was nice and patent, but I couldn't see the stone. And this is not something which is unusual, that because of the irrigation that we use, the stone migrates. And I really was afraid of this thing happening because she wanted something definite. If I pushed the stone up, I probably have created more problems, and probably I will just leave a stent and come out. That I just didn't feel well, and I couldn't understand what's happening. I had some funny feeling during this procedure. When in the middle of the procedure, I asked my resident, had she had any procedure done in the past? And she said, yes, when she was 3 years old, she had some procedure done in the bladder. And what she had was for a high-grade reflux, a Cohen's bilateral transtrigonal ureteroneal cystostomy. So on the right side, the left ureter was opening, and I was actually going into the left ureter rather than the right ureter. So took out the scope, gone into the right ureter through the left side, found the stone. remove it. It was quite a capacious ureter, and it was not difficult to catch a 7 mm stone. And the whole stone came out in one piece. So that was a big sigh of relief. So these are some of the things that happen during pregnancy. There's a lot of pressure. The patient is awake. She's also witnessing the whole story and the discussion that is going on and so on, and the spinal anesthesia. Okay, so let's come back and have a little discussion. Unfortunately, urolithiasis is the most common non-obstetrical hospital admission in pregnant women. It is seen, as I've said, in 1 to 200 to 1 to 1,500 pregnancies. Fortunately, the peak incidence is in the second and third trimester, which is, as Nadeem pointed out, a safer period in terms of intervention, allowability of anesthesia, spinal particularly, or epidural, and some of the drugs which are allowed during that period and not in the first trimester. It can result in some devastating complication with urinary tract infection and sepsis, premature rupture of membranes, premature labor and delivery, gestational hypertension, preeclampsia, and even pregnancy loss. And I'm sure that all of us have seen one or two of these complications. Unfortunately, they are not very common, but they can potentially happen. So what are the odds of forming a stone, first incidence of stone during pregnancy? Well, it is seen in women who are obese, the incidence is relatively higher. Prior pregnancy does not increase the risk of urolithiasis. As I've said, that second and third trimester is the peak period. The order of stone formation is, as I've said, second and third trimester, and it stays at a high risk in the up to 3 months after delivery. And after that, the chances keeps on decreasing. And if you've completed 1 year of pregnancy, you probably would be at the same baseline risk as you were prior to the pregnancy. Majority of the stones are hydroxyapatite or calcium phosphate stone. And fortunately, these stones are single mostly, bilateral, and multiple stones are relatively less frequently seen. Now, why pregnancy is a risk factor for urolithiasis and why women for the first time form their stone during the pregnancy? Beg your pardon. So it is because of anatomical and some of the physiological and biochemical factors. There is, we know, urethral compression and urethral relaxation under the influence of high progesterone levels. Both of these causes stasis, and this can potentially result in dilatation, which we see all the time, the physiological dilatation, right more, left less. Most of these stones are calcium phosphate stones, which is a consequence of high calcium excretion. And we all know that the calcium metabolism takes a big leap or big change during pregnancy because of increased intestinal absorption, mobilization from the bones. The hypercalciuria is something that we see, and that's why our incrustation is so frequently observed. Similarly, because of certain biochemical factors, there is increased pH of the urine. And if you close to about 6.5, 6.8 pH, you are at risk of forming infection-related stones. So very nicely summarized in this article published in World Journal of Urology some 5-6 years back, in which all the different changes, which include anatomical changes in terms of kidney size, some of the changes that we have talked about, particularly the urethral stasis, the bladder stasis, the reflux that can happen during this period, are all these factors which predispose to infection, along with the various biochemical factors, which include increased GFR. There is increased filtered load of calcium, the PTH level goes down, and all these factors results in hypercalciuria with increased uric acid excretion, oxalates, calcium phosphate. although the citrate level also goes up, and it in a way counter some of these changes which are taking place in the milieu of urine in pregnant women. However, at times it does not, and you form stones. Let's share another case. This is a 27-year-old gravida 4 para 1+2 who presented with fever, vomiting, and left flank pain. Obviously, our first line is conservative treatment with pain control, antibiotics, which are permissible during this period. However, she continued to show fever and signs of sepsis. Her white cell count gone up. She had significant CRP level as well. And all these things indicated that she is going towards sepsis. And it's important to intervene at this point in time with some kind of an intervention before she go into full-blown sepsis. And then we know that it can be a catastrophic condition. So various options of treatment discussed. Because she has a relatively big stone in the renal pelvis, our options are very limited for definitive treatment. So this patient was offered temporizing measures only. And we discuss internal stenting under local anesthetic and under spinal anesthesia. And we also discussed options of the temporizing measures like PCN. She opted for PCN. A PCN was placed, and this is a very limited one-shot picture to confirm the presence of PCN. The whole process was done under ultrasound guidance, under local anesthetic. We did follow-up scans on her with an ultrasound to make sure that the PCN is in place, the hydronephrosis settled down with nephrostomy tube, her symptoms settled down, and she was subsequently managed after pregnancy was over. And once she delivered, a scan was done on the second postpartum day. And you can see a large stone in the renal pelvis on the left side, the nephrostomy tube, part of which is visible in this picture. The peripheral uterus involuting. This was only second or third day after delivery. And subsequently, we did a PCNL, and her stone composition is interesting, and I think we need to have a little discussion on this. She had delite 70%, struvite, and brushite. So we know that the both delite and brushite are variants of carbapatite stones with calcium phosphate as a major component, and struvite is magnesium ammonium phosphate. And all these three types of stones probably require some form of a long-term treatment and follow-up. So Dr. Nasir, once she had a stone clearance, and she's still at risk within the first 3 months after pregnancy, what specific advice or generic advice would you give to this patient at that point?
Well, the first thing, you need to find out how much fluid she takes, especially in a hot country like Pakistan. We need to make sure that they can tell us exactly how many glasses of water, or what I tell my patients, 1.5 liter bottle, at least 2 bottles of water needs to be taken at regular intervals. Of course, one can give them potassium citrate and all those things to prevent the further formation. But the most important thing is the fluid intake. There are dietary advices as well, which people find quite difficult because this has to be lifelong, but then there is an element of compliance. And of course, if one has recurrent stones, we need to find out whether there is any possible pathophysiology which might be accounting for this.
Thank you. So these are the generic advice that you would always give to your stone patients, and particularly to this young lady who is still at risk of forming another stone. And particularly the infection stone are notorious. I mean, you can form a full stone of significant size within weeks after complete stone removal and treatment. if you don't care of the offending cause. And these are all infection stone, as I've said. And the mantra for treatment of infection stone is that not only you have to completely clear all the stone, and any leftover stone fragment forms a nidus. So this is something that the patient are always worried about, and we also want to take care of this, that the stone clearance should be complete. For infection stone, it is recommended that you receive a preventive dose of antibiotics, and that should be for 6 weeks to 3 months. And then those antibiotics, for the first 2 to 3 weeks, you need to give full dose, and then a prophylactic dose of antibiotic for up to 3 months in these patients. The role of acid hydroxamic acid, which is a urease inhibitor, is something which is debatable. Some people likes it and use it. It is available by the name of lithostat, and it is visible. It's available. Any experience of using this in your patients, Dr. Adhikari?
We come across so many infective stones. We just manage with, like Sir said, hydrations and trying to, give antibiotics for a long time. But this special agent is actually not available in our setup. So we actually depends on only hydration and antibiotics.
Great, thank you. There's a question about which antibiotic, and I'm going to address that point soon. So I'm not going to take it right up, and I'll give you a little. So this is a vicious cycle, infection and obstruction, leading to the, and particularly if you have the urease producing organism, which includes not only the protease, which is the most commonly found. You have ureaplasm, urolithicum, you have nocardia, cryptococcus, helicobacter, then you have Klebsiella, then you have Staph aureus and Staph epidermidis. So all these are the urease producing organisms which can cause hyperammonuria, and that cause alkalinization of the urine, and all this results in producing that screw-wide appetite cloud, which can form those huge stones that we all are aware of, the Staghorn stones. The question about antibiotic. Now, the stone cultures, which is not very frequently done outside major centers, and if any of our delegates have any experience in stone culture, please do share your experience. It is something which is not available, at least in our hospital, and as far as I know in our country. The urine culture is not really predictive of the stone composition. So in this nice study from James Lingerman's unit, reported by Engelert in Urolithiasis some 10 years back, they've looked at the urine culture and they've done the stone culture of post-PCNL stones. And their observation is that urine culture showed no association with the stone mineral content. And vast majority of patients with screw-wide stones and with aptite stones have positive cultures, stone cultures. So infection is the harbinger of, or the main focus on nidus for these stones. So choice of antibiotic, I'm not really sure, and there is no consensus of which antibiotic is indicated. I think a lot depends upon those antibiotics which can be given safely over a long period of time, because they need to be taken up to 3-4 months. And then the antibiogram of your hospital is important. Typically, quinolones or trimethoprim sulfamethoxazole are the choice, because they can be given for that period of time. Majority of your patient presents with flank pain, gross, and hematuria and urinary tract infection. The issue is with differential diagnosis. Appendicitis, diverticulitis, or placental abruption are all possibilities which are there your examination is curtailed, your ability to do scanning and other things are curtailed. So differential diagnosis is something that you should always keep in mind. Now, why we have this limitation in terms of making a diagnosis? In an ordinary patient, non-pregnant person, you would immediately send them for a non-contrast CT, hardly take 3 minutes, and you have a clear diagnosis. We have a problem with radiation. So we are dealing with a pregnant lady with a fetus. And we know that there are non-stochastic and stochastic effects of radiation, something that is always there in the back of our mind. The non-stochastic effects include teratogenesis, the stochastic effect more with carcinogenesis and mutagenesis. And the stochastic effects are something which are really dose related. So the amount of radiation that is administered. Fortunately, all these effects are seen with high dose of radiation, something that are not really administered in any of the modern day imaging. So for less than 10 milligray radiation, these effects are hardly seen. If we see this X-ray, which if done accidentally on a pregnant woman, we used to be horrified that God knows what effect it will cause. So in a plain X-ray, which only gives about 0.5 milligray radiation to the patient, is actually quite safe, and it is not known to have any significant effect. Our X-ray KUB, we know that is limited, and so is IVU is limited by the ability to make the diagnosis. Even all the stones cannot be picked up on these, and they're hardly used. So what's really the first-line imaging? The first-line imaging undoubtedly is an ultrasound. However, as we know for ultrasound, the sensitivity varies from 30 to 95%. So it's a big range, and I think this is all operator dependent, the patient's body habitus, etc., which plays a role. There is a high false negative rate of 68%. So even 2/3 of patients can have a falsely diagnosed urethral stone, which can cause problems. It relies heavily on secondary findings, which has to be differentiated with physiological hydronephrosis. And really, if your ureteronephrosis is going down the pelvic brim, it is likely to be obstruction and not physiological. What additional thing that you can do, and the resistive index is something which has been described, that if the resistive index, a mean of more than 0.7, has a quite high sensitivity, not that good a high sensitivity, it's highly specific for diagnosis. And if the difference between an obstructed versus non-obstructed kidney is greater than 0.06 resistive index, then it is likely to be obstruction than physiological hydronephrosis. So this is a little adjunct to the use of ultrasound, and it adds to the sensitivity and increasing the specificity of ultrasound. The urethral jet, again, is something that can diagnose obstruction versus physiological hydronephrosis. So if you use an elevated resistive index, you use the urethral jet, you actually increase the transabdominal ultrasounds from 56 to 72% sensitivity, diagnostic accuracy. In this interesting paper, the use of transvaginal ultrasound has been talked about, and this is another important adjunct to the use of transabdominal ultrasound. The transvaginal ultrasound diagnosed about 94% of distal urethral stones, whereas transabdominal ultrasound in this particular study was only able to diagnose 29% of the stones. So a combined transabdominal ultrasound with the resistive index estimation, the use of urethral jet and transvaginal ultrasound increase the sensitivity for the diagnosis of urethral stone to 85% and negative predictive value of 100%. So I think these are some of the things that can be utilized during our diagnostic workup. This is an interesting study on over 100 pregnant women on the use of ultrasound and using these modified things. And the authors concluded that the use of urethral jet using a Doppler is really an additional benefit in the diagnosis. Now, sometimes, and once in a while, that your ultrasound is unable to diagnose. And yes, Nadeem, please go ahead.
No, sorry, no.
Okay.
Go ahead.
Right. So the second line recommendation by both the European Association of Urology and the American Association of Urology is the use of an MRI or MRU. The American College of Obstetrics and Gynecology says that the gadolinium, the contrast medium that we use for MR, is really something that you need to weigh against benefit and risks. And gadolinium is generally not recommended because it is really a class B drug, which should be avoided as much as possible unless the risk, the benefit outweighs the risks. The special MR sequences, which is the single shot turbo spin echo MRU, it also relies on the secondary findings because we know that MR is not good without contrast for the diagnosis of stones, and stones cannot be picked up on MR. So you're really looking at the various secondary findings, which include proximal urethral dilatation. You're looking at periurethral collection of fluid, and you're looking at the double king sign, which essentially means that there is a column of ureter, distal ureter, and then there is a dilated proximal ureter, and between these two, there is a defect. So this is what you're seeing here. This is called a double king sign, and that's diagnostic of obstructive uropathy rather than physiological dilatation. The positive predictive value of MR without GAD is about 80%. Again, these are some of the examples, and you can see that a 30-year-old, 10-week pregnant, so actually formed in the first trimester, left flank pain, ultrasound was not diagnostic. The T2 weighted, the single shot fast sequence echo MR. Basically, this is an MR sequence. I'm not a radiologist, so I'll just understand what I have understood, is that this is a screening sort of MR, which can be done very quickly, and it gives you a fairly good picture of what's happening. Diagnosed a 6 mm stone in the distal ureter. The patient was managed conservatively, and she passed. This is another case of a 32-year-old, 21-week pregnant with the right flank pain and leukocytosis. The UTI was suspected. She was being managed conservatively. She didn't do well. Ultrasound was unremarkable. She ultimately ended up having an MR. And as you can see, this is the T2 weighted sequence. And this is the ADC, the diffusion weighted image. And this is the ADC map. So what you're seeing here is this wedge defect. My cursor is visible?
Yes.
Okay, so this is a wedge defect you can see in the DWI or the diffusion weighted image, and there is a corresponding ADC image with that same defect. So this is something that we know from MP-MRI for prostate, that if something is there on the DWI and it is duplicated on ADC, then we know that's an actual abnormality. So this was pyelonephritis. This patient was managed on antibiotics, and she did well. Again, this is the double king sign that I've talked about initially, and very similar situation. Now, there are situations, and we have faced in our management of these ladies, that sometimes MRI either is not available or not that readily available. This is one of the problems with MRI. So not every unit has an MRI. These patients cannot be moved from one place to another. Is CT, when I was a trainee, And in the initial years, CT was a big no-no for in pregnant women. But now the CT is very different from the CT that we used to use in the earlier years. So any investigation resulting in an absorbed dose to the fetus of less than 0.5 gray requires justification. And as we talked about, that there are non-stochastic and stochastic effects of radiation. The carcinogenesis is greatly seen if you use more than 10 milligray of radiation. However, now we have low dose and ultra low dose CT scans. So the low dose CT scan is which gives you less than 4 millisieverts of radiation, and ultra low dose can be as low as that of a plain X-ray KUB, and they are quite safe, but obviously not as safe as the ultrasound and the MR scans. So how it is performed, basically what you do is you reduce the tube current, which is in milliamperes, you decrease the tube voltage, and you are able to do a low dose and an ultra low dose CT. One of the limitations of low dose and ultra low dose CT scan is obese patient, because then the distinction and the contrast difference between stone and the soft tissue is lost. And in that situation, you probably would not be able to diagnose the urethral stones. Kidney stones can still be picked up. So these scans can really be performed in that setting. And this has many studies which have shown not only the safety, but also the high diagnostic accuracy of low dose and ultra low dose CT scan in this scenario. So if we just summarize our imaging modalities, we see that ultrasonography obviously is absolutely safe. There is absolutely no risk to the fetus. The sensitivity is low, between 35 and 94. It's quite variable, actually. The specificity is 86%. If we add resistive index and use 0.7 as a cutoff, or we use resistive index difference between the obstructing and the non-obstructing, or the normal and abnormal units, we can see that the accuracy increases significantly and the specificity actually goes up to 90 to 100%. What about MR? Most of the studies that have come have used 1.5 Tesla. However, and most of the guidelines used to recommend 1.5 Tesla MR only because that's where the studies have been done. But recently, there have been papers on 3 Tesla MR scans and the safety is as good as that of 1.5 Tesla. And obviously, we know that it's a much better machinery. So MR has a sensitivity without GAD of 77% and sensitivity of 77% and 83% of. The abdominal X-rays obviously give some radiation and they're not very sensitive. The IVU is hardly used these days. CT, again, is very highly sensitive and very highly specific, but it gives a little higher dose of radiation. So you need to really justify if CT should be done. This is the EAU guidelines that ultrasound should be the preferred modality of imaging in pregnant women, and the strength of evidence, strong use of MR as a second line and use of low dose CT as the last line in pregnant ladies. What about management, and what are the difficulties that we face in management is because of the limited armamentarium that we have in terms of the medication that can be used, as we know that the drugs have to be really safe for the fetus in order to be used during pregnancy, particularly in the first and the third trimester. Obviously, acetaminophen and narcotics are the drugs of choice. The availability of narcotics is an issue. So acetaminophen is always, and Nadeem probably will corroborate that acetaminophen is the first line and quite a safe medication in pregnant women. The problem with these patients is that there is febrile complications. It's because of the altered cell-mediated immunity. So most of these patients, women who have nephrolithiasis, end up developing infections as well because of these factors. What about other medications? Pain medications we have talked about. Antibiotics I'm going to address in the next slide. Med that Dr. Nadeem pointed out is something that we need to be careful. Its use in pregnancy is off-label, so it is not really recommended by FDA and the EMDA for I don't know about what are the NICE guidelines on the use of med in women, pregnant women, but it is at the moment considered as a category B medication. And just to remind that category A is no risk in human studies, so anything which is category A is very safe. Category B is that the no risk in animal studies, and category C is the risk cannot be ruled out. So they have to be weighed against the risk and benefit ratio to make a decision about whether they should be used or not. Again, a nice paper by Bhaskar Somani, published in World Journal of Urology about 5-6 years back, and very comprehensively looked at all the medications and when and where can they be used. And I think it's something that we should always have handy available to us who are seeing pregnant women with urolithiasis. Morphine, as I've said, is very safe, particularly low-dose, short-course morphine, and can be used in all trimesters. Acetaminophen we have already talked about. Codeine, again, is something that can be should be avoided in the first trimester because of the risk of teratogenesis. NSAIDs should best be avoided because it can cause premature closure of the ductus arteriosus. Ibuprofen and naproxen, again, in second and third trimester. The antibiotic choice is always penicillin first, followed by cephalosporins. Erythromycin should be avoided because it can cause maternal cholestasis, and sulfonamides, caution in the first trimester. Nitrofurantoin, there is a theoretical risk of fetal anemia if it is used in the third trimester in GH6PD mothers. So quinolones, as is clear in children and in pregnant women, should be avoided because it can impair the cartilage development and cause bony abnormalities. So medical management, and we know and we have seen a few cases, and I'm sure all of our experts and our delegates must have seen patients who have failed medical treatment. And when an intervention is indicated, it's because that you have intractable symptoms, obstructing stone with infection, progressive hydronephrosis, obstruction of a solitary kidney or bilateral ureteral obstructions. Bilateral stones are relatively rare. Severe hydronephrosis and high-grade obstruction. If the patient is also developing the preterm labor or preeclampsia, and I think I'll ask Nadeem after this slide that what are the real signs that as a urologist we should be looking at of these patients developing preterm preeclampsia. Just as a reminder, most of us have done our obstetrics a long time back. So these are the patients that probably would require an early intervention. So before I move on to those intervention, just a little quick word from Nadeem, and then we can move on.
Okay, so Hamad, in terms of antibiotics, you have very clearly mentioned about the usages. And I think for antibiotics, the penicillin group remains the most safest of all to be used. And in terms of when we are talking about any risks to the pregnancy, obviously the first trimester is the most highest time when the risks are higher, and most of the interventions are preferably avoided. In terms of looking at any risk factors for preterm and preeclampsia, one needs to keep an eye on their blood pressures, number one. If their diastolic is going above 90 millimeter of mercury, it is a matter of concern, as well as if the protein, she's losing proteins, or protein creatinine urine spot is going more than 0.3, then one should take a look at it, whether it's deteriorating or not. So overall, these are the basic things that one need to look after. In terms of in the second trimester, other thing which is more common is a preterm labor. And for preterm labor, obviously it's a very obvious sort of a complaint, which is a patient will complain of discomfort or a pressure or tightenings or contractions coming and going. And if she gives these kinds of the symptoms, then we should seriously think of doing any interventions in terms of urology also, along with the pain relief and usage of progesterones.
Thank you. So obviously, one of the first things that you talk about is temporizing major, which is divergent. So we do it either with a percutaneous nephrostomy, something that is done under local anesthetic, completely under ultrasound guidance, or a double J stent placement. The percutaneous has an advantage that it can be used, like in our patient that I've discussed previously, to do PCNL in after delivery. Higher insertion rate because success is quite high with the dilated systems, shorter operating time, lesser incidence of post-urinary tract infections. So these are some of the advantage of double J stent. However, facilitate subsequent ureteroscopy. The operating complication can sometimes be higher, and it should be preferred for proximal ureteral stones. The problem with both these interventions is that because of the very high turnover of calcium, there is high chances of incrustation of these tubes. So they may require replacement, maybe even in weeks. So one has to be really careful about putting an internal stent and keep changing them every 4 or 6 weeks, which becomes quite bothersome. What about endourology? Well, ureteroscopy is again the choice, and it is something that can be used very safely, and we and all of us have experience. The stone-free rate is quite high. It is ideally should be done in the second trimester. It can be done under local anesthetic because the ureter is quite dilated, but preferably under spinal anesthesia. G is definitely avoided in the third trimester. It should ideally be done under ultrasound guidance. So the lack of radiation or fluoroscopy during ureteroscopy is one of the limiting factor. However, trained endourologists are able to do this procedure quite easily. So they should preferably be managed in center where there is significant experience. PCNL is a very high-risk procedure and should best be avoided as much as possible. Shockwave lithotripsy is a big no-no, and there is absolutely no reason to do ESWL during pregnancy. There are, as we have talked about, advantages and disadvantages of internal versus external stenting. And Mahesh, any views on your preference on the temporizing majors in terms of internal or external stenting?
Yes, sir. Sorry. Okay. Something is not good.
We can hear you very well.
Okay.
See you now.
Yeah, my opinion is again same thing. We discuss with the patients the advantage, discuss about the advantage, disadvantage of all these procedures, and definitely it looks like all the guidelines they're all mentioning ureteroscopy as the first line, especially the American Urological Association guidelines advocating ureteroscopy as the first line, and but it seems that none of these trials or the papers, the numbers are not very good. They're all around 50, 60, and hundreds. So depending on the discussion with the patient, I'll definitely, rather than doing an internal stent, I'll definitely go for ureteroscopy. Stent internal.
I think yes, it's a very reasonable thing because your need, particularly if you are somewhere closer to early part of the second trimester and you have long time to go, a definitive major is definitely a better option rather than the temporizing major. If you look at this interesting paper where they have looked at the mean stone-free rate complications in various complicating situations like larger stone, bilateral stone, obesity, or obese patients, pregnancy and pediatric, and so on. And I focus your attention on the pregnant women. The ureteroscopy has a stone-free rate of 85%, which is fairly high for a procedure which is slightly compromised in terms of lack of use of fluoroscopy during that procedure. So if you look at the summary of evidence in the European Association guidelines, stent insertion seems to be more effective than conservative treatment in the management of symptomatic moderate to severe hydronephrosis during pregnancy. And this is the guideline 1A evidence. Ureteroscopy is a reasonable alternative to avoid long-term stent and drainage. And as Dr. Adhikari has pointed out, and Dr. Suleiman has also pointed out, that you need to really focus and talk to your patient, talk about the pros and cons. And most of these patients are really able to make a decision because they need to see whether taking a risk for half an hour, 45 minutes, rather than suffering for the next few months is what they would prefer. Stent infiltration, as we have said, is really an issue. This is an interesting algorithm. I don't really need to go into the details because we have talked about most of these issues. So in summary, pregnancy confers an increased risk of first-time symptomatic kidney stones. This is important to remember. It peaks just after delivery, a second trimester it starts, peaks after delivery up to 3 months. And by first year, the chances of forming a stone in the next pregnancy would be baseline. Pain and sepsis are two of the complicating factors, along with adverse birth outcomes. So these are the things which really makes you take a decision in terms of abandoning the conservative treatment and going for some more definitive treatment. There are challenges with diagnosis. There are challenges with the treatment, and really the close coordination of an obstetrician along with radiologist and urologist. So really doing a multidisciplinary approach in the management of these ladies can bring the best outcome both for the mother and for the baby. So I thank you very much for your attention, and I see quite a few comments and questions. So let me take these comments. And so what about Generin Fort for longer period? Now, Generin Fort is not really recommended in pregnancy. The safety it is classified as a category B. So it should best be avoided if possible. There's another question. Should calcium supplements commonly given in pregnancy needs to be stopped? Interesting questions. So what is your practice, Nadeem?
No, they should not be stopped. Idea is that they should continue with their calcium as well as, but they can take it with the meal. The preference would be they should take the calcium with the meal, and it should not go beyond 2,500 in a dosage. And one should monitor the stone, but there is no reason to stop the calcium in these patients. But they should take it with the meal.
Okay, right. There's a question from Shaila Bakai. In pregnant patients, MR is commonly used for the evaluation of acute abdominal pain. In MR, there is no ionizing radiation exposure to fascia. Okay, so this is a comment. And yes, I agree, Dr. Shaila. It is correct that MR can be safely used. And as we have discussed in the presentation as well, ultrasound is indeed the first line in majority of cases. And with some of the adjunct that I've talked about, really can improve the diagnostic accuracy of ultrasound scan. What is
Phase-
RI? The
Yeah.
question from Shabir Nas. Well, RI is resistive index, and this is a calculation that you make for the flow. And if the resistive index is greater than 0.7, then there are greater chances of obstruction. If there is a difference of greater than 0.06 between the normal and the abnormal unit, again, that's a very good indicator of obstruction rather than Shaista asks, calcium with vitamin K, maybe she means vitamin D, may reduce the chances of stone formation or not. Dr. Nasser, any comments? You're muted, sir.
I would request Dr. Nadeem Zubairi to comment on this.
Okay. Okay. So if we are talking about the K thing, then K is something which is coming up more recently to be used when you are using the calcium and the vitamin D, and it helps in absorption of the vitamin D also. So especially if it is being used, it is used in that context. One comment I want to make, Hamad, is somebody was mentioning about the RI, and you very clearly mentioned about that if it is more than 0.7, it indicates obstruction. But the first trimester usage of this Doppler has been cautioned that if you are using it in that, the heat that it generates, and if it raises the temperature to 1.5 degree, then the fetal embryo is a very sensitive being. And people have seen problems with that. So overall, Doppler study in the first trimester, preferably for RI reason, should be avoided and should be kept for the second trimester and onwards. So I think this
Thank you very much. I think that's a very well addition. So a good point. There's another question about the use of alpha blockers by Bhatti. Well, MET is what I referred to. MET is off-label and category B, so should best be avoided at least in the third trimester and the first trimester. B in trimester, second trimester, again, if in the opinion of the treating urologist and the obstetrician that it outweighs the benefit, the risk, then again it can be used.
Dr. Ahmad, in pregnancy, what I know of is that if somebody is using alpha blockers, if non-pregnant versus pregnant, the success rate goes about half. So from 97, it goes down to something like 40, 44 or something. So its usage with caution as a drug B is there, but its effectiveness also substantially goes down during pregnancy. So one has to weigh whether they want to use or not.
Right. There's a question from Dr. Pramesh Shrestha about gestational age. Would you go for JJ stenting instead of PCN? So as I've said, that JJ stent is either done under local, replacement can be done under local, but it's preferably done under the spinal anesthesia. And the JJ stent life is really very short in pregnant women. So it gets encrusted very quickly. And once it gets encrusted, there is a chance of obstruction and infection, and that could be disastrous. So replacement of double-J stent becomes imperative. So if you do it in the early part of second trimester, you would require quite a few exchanges before this lady delivers. So one really like to avoid this in the early part of pregnancy. Nephrostomy again has a problem that it has to be carried for months. It's a tube coming out from your back. They have already problem in sleeping. The positions are limited. If you have another tube in your back coming out, then it becomes even more difficult. So these are the things that one needs to be careful about when deciding these things, and discuss it with your patient, that what is really their best bet.
Dr. Hamad?
Yes, Dr. Mahesh, please go.
Nowadays, the people, I mean, the companies are coming with this silicone long-lasting stent. Do you think it will help during pregnancy?
Yeah.
regarding this incrustations and all?
Yeah. So the use of the silicone stents is what should be preferred and so I only use silicone stents for pregnant women. But again, the level of and the degree of incrustation varies between patients. Some of these ladies can actually incrust even a silicone stent, and some of the new generation stent, which apparently because of such a high level of excretion of calcium and phosphate during that period, that maybe in a normal situation, in a non-pregnant patient, they probably would encrust late, but during pregnancy, it is really an issue. So, right, then there are some.
Somebody was asking whether you can add calcium and vitamin D during, I mean, pregnancy,
Right.
but it is said that this placenta also produces a lot of 125 hydroxy calciferol that increases calcium absorptions from the GI tract, and also actually if you give more vitamin D, it suppresses parathyroid hormone, and that will also increases more hypercalciuria. So it may not be recommended. Is it true? Or?
Nadeem, your take?
I didn't get the question.
The question was use of vitamin D along with calcium. So calcium is something that all obstetricians like to, because you obviously need
Absolutely.
a lot of.
So here specifically only calcium would be preferred to use with meal, and one can skip in the specific circumstances the vitamin D and vitamin K in the specific case.
Thanks. So there is a question from Pramesh again about the precipitation of labor during an endourological procedure. Again, as I've said, that the close interaction between an obstetrician, the urologist, the anesthetist. So anesthetists who are well-versed in obstetric anesthesia, and I've actually invited our obstetrician anesthetist. Unfortunately, she was not available, but I think her input would have been valuable. So the close interaction between these three really can avoid any preterm labor or precipitation of labor during an endourological procedure. So you need to take care of pain. You need to make sure that the patient is adequately hydrated, and you monitor. So I always ask the obstetric residents or obstetric teams to come over and monitor the fetal movements during, before, and after the procedure, so that if it is needed, we need to keep them under close observation.
Ahmad, one can also, just like you said, keep them well hydrated, infection prevention, and pain relief, and also progesterone usage may be a good option in them. And nifedipine per se is also a sort of a relaxant there, which also facilitates the expulsion of the stone, which is already one of the modality. But use of progesterones in terms of their suppositories available, their oral supplements available of progesterone varieties in the morning or afternoon dosage, or maybe a 3-time dosage, depending upon the situation, one can use them, and that could help sort of reduce the risk of miscarriage as well as the pregnancy preterm labor.
Great. I think we had a wonderful session. I'm really grateful to Dr. Nadeem Zubairi, our very trusted gynecologist obstetrician, Dr. Nasir Suleiman, with whom I have managed a lot of these cases, and our guest tonight, Dr. Mahesh Adhikari. Thank you very much for taking time out from your busy schedule. So, and I'm really grateful to all the delegates for their very passionate involvement during this session. So hope to see you again next month in our next webinar, which will be our 30th webinar of the Conceptual Basis of Urology course. Until that time, have a very good weekend and good night.
Thank you, Dr. Hamad. Thank you very much.
Thank you.
Thank you. Thank you very much.